about it, which they think is not good. So they're going to rewrite all their questions. And I've also heard that they're going to up the antes. They're going to increase the difficulty level. So the basic points that they've included in their criteria for writing the questions is that you're going to have a whole lot of uncommon presentations of common conditions, and you will have a whole lot of common presentations of uncommon conditions. So which is what we will focus on. Okay, so you will, if there's an uncommon condition I'm showing you, it's a rare entity I'm showing you, it's going to be a very typical presentation of it. If it's a very, that's a ischemic bowel or a common thing that you come across, it will be a very unusual presentation of it. Okay, so it's not going to be something that a first-year resident or first-year registrar can pick up. It's going to be something that will require a bit of thinking, a bit of experience. So that's how we have designed these questions. Now, this is the very first course, so I didn't want to complicate it too much. There's a whole lot of easy questions in it as well, just to get us started. But in the subsequent lectures as we go along, there's going to be difficult stuff. Why? Because the goal is here to prepare you for 2A. There's stuff that you may never read. So our goal is to give you the clues, the keywords. So every condition will have a keyword. As soon as that says, so for instance, tigroid pattern. So leukodystrophy's tigroid pattern. So if you hear the word tigroid pattern, you should not think of malignancy, you should not think of infection, you should think of leukodystrophy, demyelination disease in a child. So we're going to give you keywords. So program you in a way that when you get these questions in the real exam, straight away you know what they're asking, what they're thinking about, what they want to know. So that's why these sessions are going to be harder than what you expect at the actual exam level, because that's what we're doing. We're preparing you for the 2A. We want you to pass straight away, and the recalls may not help you anymore. So you will have to drill it into you. So do not be alarmed if you see stuff that is difficult. Okay. Anyone's got any question at this stage? Or we can start. We can crack on. Okay. Becky, I'm going to keep on needing your, because this is my first session as well, so I'm going to keep on needing your guidance about running this thing. So I'm going to run the poll here. Is that correct?
That's correct.
Okay.
I've put, for the ones, there's a few who've just joined.
Okay.
I'll put the link in again. All you need to do is click on that link and it'll take you to the poll, and you can take the answers there. So click the one that you think is the most probable answer.
So go
If
ahead,
anyone
everyone.
needs, sorry.
Take your time. Read the question.
If anyone needs any extra help with that, just let me know. Once everyone has Slido on, could you let me know on the chat, or could you just unmute and say that we have it ready? Or you could use the reactions or whatever to just maybe put a thumbs up, or, you know, so that I know that everyone's on board. Can you guys hear me?
Yep, we can see the poll fine. Thanks.
Okay, perfect.
Becky,
Is everyone...
when do I know when the poll's been attempted by everyone? Or can you see it at your end that it's been attempted?
So I can see 5 people have taken the poll on top, on the right-hand top. Yeah. And we have about 8 people on the call. So let's just wait for a few more minutes to see if everyone's come in. If anyone needs any help, do let me know. I know that all of us are not very familiar with the platform. Okay, I think we could move forward.
Okay. It's still kind of running.
Are you thinking of
everyone-
sharing your other screen, Doctor?
No. I'm going to talk about this now. So can everyone see my screen? You don't move this one here. There you go.
Yeah, we can see it. We can see the Slido screen.
Okay. So that very well done. So you guys have mostly picked up the correct option. Let's go through the wrong options first. So leg calf Perthes disease, rickets, thanatophoric dysplasia. So thanatophoric dysplasia you can rule out straight away because it's a fatal musculoskeletal dysplasia. Kids 11 years old, they rarely make it to that age, so that's gone. Rickets do not cause short stature and pectus carinatum, so that was good. We ruled that out. Leg calf Perthes disease again does not cause. It's not a skeletal dysplasia as such. It's just a hip abnormality. So that is being excluded very well. No one picked these up. Now these two, yes, osteogenesis imperfecta can be remote option. But why it's not the correct option, because this is also one of the fatal skeletal dysplasias, and again they do not make it to 11 years old. However old they are, they can have a short stature because of the recurrent fractures of the long bones, so they don't grow as well. But the pectus carinatum is not their typical feature. Same goes for coarse face. There's a couple of things. Now, this is not a common disease. I don't know how many more cases have you seen. This is not a typical disease. Now, I've given you an unusual disease, which means I have to give you clues. Very clear. Our job is not to sway you away from the correct option. Our job is to get the information out of you. Okay, so I've given you more clues here. Mother reports the child was normal at birth. That is a very, very unique characteristic of Morquio. They're remarkably normal at the birth, but then very rapidly the skeletal dysplasia starts to show up, and by age 1, there's a whole lot of abnormalities. So that's a very unique feature of Morquio. None of the other listed ones have this feature. All of them, except for leg calf Perthes, obviously, will have some appearance. The other thing is the central peaking of the thoracolumbar kyphosis. So that's seen in Hurler's disease. That's also seen in achondroplasia, which is not here as an option. And then kyphosis and knock knees is also a characteristic features of it. So this is the point I was trying to make, that if we give you an unusual presentation, there will be enough clues, because one of the targets that we were given is that once the candidates read the stem, they should be able to get to the answer without reading the stem. Okay, so that's why we have to, in an unusual or uncommon condition, we have to give you enough clues that you know the answer by the time you've read it. Okay, it does require you to read a lot, but that's why we are here, and this is why we are doing these sessions. You're going to see a whole lot of these things, and hopefully by the end of it, you'll know most of it. You should be able to comfortably cruise through your 2As. It's just a quick. Can you see my screen? Can you see what I'm showing you? So that's a Morquio syndrome.
Yes.
You can see the pectus carinatum. This is exactly the facies, regardless of what ethnicity they are. And this is the kind of face you get: short web neck, pectus carinatum, remarkably short stature, very short stature. So it's very unusual that these kids are completely normal when they're born and they get to this. Knocking knees, atrophy of the lower legs, hypermobile, so much longer arms compared to the legs, hypermobile joints, etc. So that's Morquio for you. And then in the slide, how do I get to the slide? Here it is. This is the central peaking. Okay. Now, this is not typical.
Syed, would you be able to maybe make that a bigger screen, just present it so then we could see it a bit more larger?
Yeah, sure.
Perfect. On top.
Slideshow.
Yeah.
On the front slide. There you go. Can you see it better now?
Yep, thank you.
Yeah. I don't know how to remove this bar. Can you guys see this bar at the bottom, or is this in front of me? You can see the picture clearly?
We can see the
Yes,
picture.
you can see it. Thanks.
Okay. Okay. So this is another feature. So remember that this presentation, this tipping or the central peaking is seen in achondroplasia. But in achondroplasia, they're usually more rounded like this. Okay. You can see tips here and there, but they're more rounded. If they're proper beaks, proper bird beaks, there's not a whole lot of options. It's Hurler's disease and it's morculous. Okay. So the three main ones that you will come across. Hopefully you get any three of these options. There will be other clues to which diagnosis they're trying to get out of you. Okay. So let's get back to the next question. So just press this one to get to the next one, is it?
You can stop this and then just yeah, that's right. Yeah.
Okay. Everyone, go for it.
Sorry, just a quick question about the previous one. So you said there's achondroplasia, morchion. Who's the third one?
Hurler's disease, Hurlers. That's also a skeletal dysplasia from a lysosomal disorder, I think, and not a short stature abnormality, but it shares the spinal findings with the achondroplasia and the mucopolysaccharidosis. So just the spinal findings are the same, other features are completely different.
Fantastic, thank you.
Okay, it'd be
Yeah,
nice if
go for the
everyone
next one.
hops back onto Slido and takes this question. If anyone needs the link again, just let me know. Okay, let's give it some more time. I see 5 people on Slido now. Hopefully everyone can take these.
Yeah, don't worry about it if you're getting it wrong. This is that's why the whole point is we want you to get it wrong now rather than get it wrong in the real examination. We will talk about it shortly. So whatever you think, if you don't know the Goldman classification, then obviously you might just have to take a guess at it. But if you kind of remember the Goldman, just click the one that you think it fits under. Becky, let me know when all's done.
Yeah, we can give it a minute more, I think. Okay, yeah, we could move to the answer. I think everyone has taken the poll.
Okay, all right. So most of you picked up type 4. Some of you picked up type 3, some type 2. No one picked up 4A and 1. So basically, it shows that you have a general understanding of the classification system. And you're confused in this, and that's justified because this classification is idiotic. So that's another thing we're going to come across. Classifications that make absolutely no sense, no pattern to it, and it's just memorizing. Mr. Goldman, I don't know what basis he divide. We'll talk about, put it in front of you, but because it's now an accepted criteria, it's what the urologists, the surgeons take into account when they speak to each other. Is it 3? Is it 4A? Is it 4? So it's kind of become the norm. Unfortunately, we do have to memorize this. So that's the other kind of thing that I'm going to incorporate in my teachings. That this thing that doesn't usually make, it doesn't follow a pattern. It's just somehow someone thought this is how I should do it, and it is stuck. So you and I, we are now stuck with it, and we have to memorize it the way it is. Okay, so this is the other one. So that the correct answer is 3. And on the current slide, there you go. So if I was to do it, or if I gave you to do it, you might say that we will do the anterior urethra, then the membranous urethra, then the prostatic. So go from front to back or go from back to front and number them accordingly, which will make sense. Okay, 1 and 2 anteriorly, 3 in the middle, 4 and 5 posteriorly. But that's not exactly how it is. There's no pattern to it. Unfortunately, this is something you do have to remember. So just pay attention. So the type 1 is when it is stretched at the membranous urethra. Okay. The type 2, when it is torn at the membranous urethra. Type 3, it is torn at the membranous urethra and goes through the diaphragm, which is the case that I presented. The fact that there is contrast above and below means that the diaphragm is damaged. Number 4 is the prostatic urethra at the base of the bladder. Number 4A, surprise, surprise, does not involve the urethra at all. It involves the bladder, but sparing the base. So it's not even a urethral injury, it's a bladder injury. Mercifully, he's called it 4A rather than 5. So if it's 4A, just remember it's not a urethral injury at all. And then anything in the the anterior urethra is 5. Is everyone clear about it?
Yes.
Any questions? Yeah, so as I said, there is no pattern to it. Again, this is something you just need to memorize, unfortunately. Maybe surgeons have a reasonable explanation for why they've done it like this, but this is how it is. Okay, let's go to the next one.
I think we can move on to the answer. It looks like everyone has taken the poll.
Okay, I'm just going to ask a question before we start talking about this. What do you guys think? Is this a hard question? Is this intermediate? Is it very hard? Is it easy? What category do you think this question is? Anyone can answer. Is this a easy, intermediate, hard, or very hard?
Hard, but I've not done enough revision.
Oh, okay. Is everyone else agrees on this one?
Yeah, I think it's tricky
Yes.
because we're sitting like I'm sitting at the exam in November, so we just started reading now, so everything is difficult.
Yes. So that's the third point. Okay, that's another thing. There will be subtle differences. So your main knowledge will sway you in a different direction, but there'll be something in the question which changes the answers completely. So as a general rule, anything in the abdomen that is within the tummy, so from the diaphragm all the way down to pelvis, anything there in the abdomen, any malignancy can cause peritoneal carcinomatosis, okay? Anything can cause omentoperitoneal disease, so from stomach to duodenum, small bowel, large bowel, rectosigmoid junction, anal canal malignancies, uterine malignancies, cervical malignancies, ovarian malignancies. They can all cause omentoperitoneal disease, right? Basically, whichever cancer is more common than the others will cause peritoneal carcinomatosis more commonly, okay? That's basic stuff. But we've said that these are calcified. So the calcifications within the peritoneal carcinomatosis is actually rare, and it's done by ovarian malignancies. So remember that for your MCQs. So if it was an intermediate difficulty question, they will be asking you about ovarian malignancies. I have not put the ovarian malignancies in the option at all. And you guys correctly picked the gastric mucinous adenocarcinoma. So if there is a gastric malignancy and there is calcified peritoneal carcinomatosis, it has to be mucinous adenocarcinoma. Okay, it won't be the standard adenocarcinoma. It has to be the mucinous type because they're the only ones from stomach that will cause calcifications in the omentoperitoneal. Otherwise, by far, the most common one will be the ovarian malignancies. But ovarian is not an option here. So that's the subtle thing in this. Or while we're at it, the gastric mucinous ones are a bit tricky for us because I'm in a cancer hospital. And they are a constant source of problem for us because one, they are PET positive only on 17% of the cases. So there's a good 83% of the time they're not the PET negative. So, and a gastric mural thickening, because we don't have a cutoff for it, we see subjective gastric mural thickening symptoms that fit. And we do a PET scan and it doesn't give us activity, it doesn't help us. We get activity, yes, we confirm it, it doesn't help us. But if there's omentoperitoneal disease and they have calcification, and it gives a very, very good thumbs up towards the diagnosis of gastric mucinous adenocarcinoma. So these are those subtle things which otherwise you'd have to read books and books about to get to that point. So that will be the fourth thing that we're going to do in these exercises, to give you those subtle things. It's probably good if you make notes of these little things. So if you see, if there's a question about peritoneal carcinomatosis, it's going to be many things, okay? It's going to be many things. Stomach's more common, so the stomach will do it. Ovarian followed by ovarian, so ovarian can do it. If it's calcified, it's ovarian. If the ovarian is not in the option, then it has to be the gastric mucinous adenocarcinoma. Okay, so we're going to move to the next question. Any questions from you guys?
Yeah, just one question, Dr. Shahzad. If you had colonic mucinous adenocarcinoma as well in this list, would you pick that just because it's a far more common?
Yeah. So because the mucinous is more common in the gastric, but that's why gastric mucinous. If it is a mucinous of the appendix, or if it's the mucinous of the colon, yes, they can be calcified as well.
Thanks.
Any other question? Yeah. Any other question? Nope. Okay. Go forward. Okay, is everyone done?
Sorry, I think they're still taking the question.
Yeah, that's all right.
I'll
That's all
just
right.
give it a
So
minute more.
take your time. This is another like a discussion case, and it's an important one. So take your time, folks.
No worries. I think we can go to the answer side now. Everyone seems to
Yeah,
have
that's good.
taken.
That's good. So I was hoping to get this kind of response. So these are the two differentials that we are struggling. The other three don't make sense, like osteoidosteoma, it's not. Osteoporosis is not a focal lesion. Osteoblastoma, again, not tiny lesions, they are not multiple. So you rightly did use the two that we are concerned about here. So you look at a bone lesion, you go to T1 straight away. I'm pretty sure that's what you do. And T1, low T1 is badness. So low T1, bad. But is it necessarily bad? So you look at T2. So if there's any malignant component in it, if it's a primary, if it's a breast metastases, sclerotic metastases, there should be some inflammation, any water-related image, stir preferably, so you don't have fat signal in it. You will see somehow a signal, okay, which will help you decide if this is a normal bony island or this has some malignant component into it. And then if you give contrast, I haven't given you that information. If you give contrast, it will enhance. So I intentionally didn't give you that information of enhancement. Now you're left with two things to consider. Is it bone island or is it sclerotic metastases? What's the other clue? The other clue is stability. So I've given you in the history that there's a previous MRI which shows that they were there and they're the same. So that's where you will decide, okay, they're probably asking about bone islands rather than sclerotic metastases. So this is, as I said, when we give you a common condition, we give you, so this is usual stuff you come across. We give you a common condition. It will be an uncommon presentation of it. It will be tricky. It won't be easy to get to. So there is evidence that it is low on T1, low on T2. There's evidence of calcification in it. No high T2 signal, as says the question, and then there is another evidence to its stability as well. So the preferred answer in this case will be anostosis. And you will get a whole lot of these, unfortunately. They will have one or two that are very, very close, unfortunately. and you will have to decide the best option. So which in this case is the anastosis correctly picked by majority of you. Any question? I guess not. Okay, move to the next question.
Okay, I think we could give one more minute. I don't see everyone on the call. So, do you guys need more time? If you need the link again, please let me know. It's on the chat, but yeah. Okay, I think we could go to the answer now.
Okay. Yeah, so you've done well. I can see there is a bit of a confusion here. This is probably the one where I've had the most divided opinion, which is fine. Okay, this is another point. Okay, so nice guidelines are used all the time, right? You will have some knowledge. If you don't completely remember it, you will be confounded, and it will actually be counterproductive, and it will get you to the wrong answer. Okay, so whoever said follow up is correct. Why is that? Okay, there is one particular section in NICE guidelines about GCS 15. So if the GCS is 15, when do you get the CT head? GCS is 15. But when there are a few, there's about 5. So the first is, so according to the NICE head injury guidelines, the risk factor for people who have GCS of 15, the risk factors are age over yeah.
Is
More than
Dr.
one
Syed's
episode of vomiting,
internet breaking up for anyone
high
else?
risk of bleeding.
Sorry,
Can everyone hear me clearly, or you guys, is it? Can everyone hear me?
It was breaking up there. It was breaking up there for a minute, but
okay, sorry about that. So I'll just start from the beginning. Okay, there's in the NICE guidelines, you use it a lot. You probably know the main part of it. GCS is less than 13 and blah blah. What you need to do. There is a small caveat in it. There's a small section in again. So this is why I put this question in. So even the things that you use daily, there will be some part of it which you probably don't pay too much attention to, rightly so, because in real life you don't come across them. And that's what they're going to use. They will use that part. So this is another thing, the guidelines which are commonly used, the parts which we don't pay attention to. So this is the one that we don't pay attention to. What if the GCS is 15? Do we take this patient for a CT head or further management or not? So we do only if, number one, the age was over 65. Not capable for bicycle, okay? If there was more than one episode of vomiting, okay, there is a high risk of bleeding. So the patient's on warfarin or, you know, any blood diaesthesia, any past medical history of disorders. And you can see none of that is being given in this question. It is a trick question, but I put that intentionally in. This is one section of the NICE guidelines where the GCS is 15 when you do CT, only if either age is above 65. There's more than one vomiting, not single episode of vomiting, more than one episode of vomiting. Patient is high risk for bleeding. And you can see, or it was a high impact trauma. I can intentionally put all the low risks in there. So in that case, the correct option is follow up, not to do a CT scan. Any questions? So that's another thing you just need to memorize. Okay. No questions. If you stop hearing me at any time, because I don't realize that my internet's breaking up or anything. So if you can't hear me, stop me straight away or message me. Next question.
Hi, Dr. Syed.
Yeah.
Can I ask a quick question about the last one, the
Sure.
CT head question? Just with the NICE guidance, bicycle collision is under an indication for CT head and report within an hour. Does that not include falling off a bike, if that makes sense?
No. So if it was a head-on collision of bicycle with a stationary or a moving object, then it does come under moderate to severe. But if he just fell off a bike, stumbled on a rock or something, that's a low intensity trauma.
Okay, that's helpful. Thank you.
No worries.
I think everyone has taken the poll. We could move to the answer for this one.
Okay, so anyone, just in fact, Crispin, was it? What do you think? Is this in which category is this? Easy, very easy, intermediate, difficult? Anyone? Is it an easy question? Hard question?
Syed, could you repeat the question? I don't know. I think there's still a little bit.
Okay, I'm so sorry. My internet seems to be fine here. My question is this an easy question? I just want to know from the candidates, what do they think? Is it easy? Is it difficult? The question.
I mean, it's one of those questions that either you know it or you don't, I think.
Exactly. So that's the fourth kind of question, okay? You either know it or you don't, because it's so subspecialized. So I have fellowship in neuromusculoskeletal PET. This question I remember specifically because the same question was in Franska in Australian exam. And the same question was in UK exam as well. So this has been deeply inspired by that question. I have changed it just a little bit because we're not allowed to copy them completely. I've just used it as an inspiration. But you'd be surprised, they will put stuff in the examination which they think you're not going to read up on. Rightly so. This is an MSK fellowship thing. This is something you learn when you do your MSK fellowship, not when you're doing your residency, but for some reason it will still be on your exam. So that's the fifth kind of question that we're going to incorporate in our teaching sessions. The things that you may not read in your routine, revision. This will not be part, you're not going to go and read up about pulleys and pulley injuries. So that's why this session will be helpful. What you take away from here will pretty much cover all your pulley answers. So this one, the correct option is A2 pulley, and I'll tell you why. Let's quickly go through the pulleys. Hard to remember, but they're not actually, okay? So you've got three pivot points. You got the MCP joint, you got the PIP joint, you got the DIP joint. There are two pulleys across the MCP joint. There's one right on top of the PIP joint, and there's two across the DIP joints, okay? Easy to remember. Now you can easily remember where the A1 pulley is, where the A2 is, where the A3 is, 4 and 5. And their job is to keep the flexor digitorum superficialis and flexor digitorum profundus down stuck to the bone, right? Now, by far, the most common, because the most under stress joint is this one in climbers. So if the word climber, mountain climber, or professional climber, competitive climber comes up and they're asking about the pulley, they're asking about A2 pulley. By far, the most common injured pulley is A2 pulley in the climbers, okay? So I also gave you other clues to bowstring. So this is how if the A2 pulley is gone, this becomes like a bow and a string appearance. And we do refer to it as a bowstring on an MRI, even on a CT sometimes. But again, if you know it, you know it. You don't know it, you don't know it. So this is another thing we will teach you about things which you may not read on your routine revision. This is one of them. Just carry it. If they say climber and they're asking about a pulley injury, it's A2 pulley they're asking about. The only other thing they may ask you about is the trigger finger. Anyone heard of trigger finger? I'm sure most of you would have. Can anyone just tell me which pulley is involved in trigger finger?
Is it A1?
Exactly. So it's the synovitis, or we call it obstructive synovitis of the A1 pulley. So there's adhesions, tiny little adhesions that develop within the A1 pulley, and they don't let the flexor tendons pass through smoothly. So it lets it go in tiny little jerks, so you get that trigger finger. And MSK radiologists, we can go under ultrasound, put the needle in there, go all around it and break those adhesions, and the patients become normal straight away after the procedures. One of those procedures very satisfying because the patient is treated straight away. So For pulleys, hopefully you're not going to be getting too many questions. One, just remember where they are. Know that climbers get pulley injuries, and it's by far the most common is A2. And then if they ask you about trigger finger, they're asking you about A1 pulley. Any question? Oops, sorry.
No.
Yeah, I think we're good to go to the answer now. It looks like everyone has.
Yeah, so again, one of those questions where the jury is completely divided. And again, rightly so, because this is one of those. So again, I told aneurysmal bone cyst is a common thing. Okay, you probably all see it once a week, a few times a month at least. And then if you pick up any MCQ books, you will see a few questions about aneurysmal bone cyst. Again, common thing, but the question about it will not be common. It's going to be some technicality on that question. And this is one of those technicalities about aneurysmal bone cyst. Just remember, just commit to your memory that other than the intraosseous lipoma, so most of the aneurysmal bone cysts that you see, like extensile lesions, fluid levels, sometimes bleeding within, they are primary, okay? They're not associated with other lesions, but there are 4 conditions which can give rise to an aneurysmal bone cyst. Those 4 conditions are the chondroblastoma, fibroxanthoma, osteoblastoma, giant cell tumor. The only one that does not give rise to an aneurysmal bone cyst is an intraosseous lipoma, which is the correct option in here because it says except. Okay, so again, one of those common condition, but a difficult question, uncommon presentation. Again, something you just need to commit to memory. Chondroblastomas, osteoblastomas, 2, giant cell tumor, 3, and fibroxanthoma. Now, while we're at it, can anyone tell me the other names to fibroxanthoma? Because if you get this stem, you may not say fibroxanthoma, it might say the other 2 names for it. What are the other 2 names for it? Anyone, shout out. Non-ossifying fibroma and fibrocortical defect. Okay, so it's different from center to center. Back in New Zealand, we never used the word fibroxanthoma. We used to say ossifying fibromas. In Australia, they like to say fibrocortical defect. They're all three of the same things. Subtle differences, but that's just nitpicking. So that if you get this question, it might not say fibroxanthoma, it may say NOF, it might say fibrocortical defect. Which is a point to remember is the two blastomas, the chondroblastoma, osteoblastoma, the GCT, giant cell tumor, and the fibroxanthomas can give rise to a secondary aneurysm of bones. Take it now. Right, next one.
I think we could move to the answer. We have everyone looks like they have taken
Yeah,
the test.
so yeah, sorry. So this is another one of those where the condition is clear. You probably all know that this is a hydatiform mole. The question is unclear. Okay, the question.
Dr. Shahzad, we are
Question
not
would be
able to hear
tricky
you.
about it. So again,
I'm not
full
sure if it's just
presentation.
me, if it is
Completely? Can
It's-
anyone
it
hear
was-
me? Can anyone else hear me properly?
It's breaking down every so often.
Oh, okay. Let me see.
Now looks a bit better. Sounds a bit better.
Okay, all right. So everyone can hear me correctly now?
Yes.
Yeah, okay, perfect. So this is another one of those questions where the condition is common. Well, it's not common, but this is something that you will read up about in all your MDTs and grand rounds and meetings and etc. Things like these will keep on coming, and you will see a lot of questions about it. So we know that you'll be exposed to this. We know that the few clues will tell you this is hydatiform mole we are talking about, right? But again, when you see a simple entity, just remember that the question is not going to be easy about it. Let's go through it. There's a 36-year-old pregnant lady, so the age is already high. Had an ultrasound because the obstetrician found this is large for age. First clue, patient has hyperemesis. Now, not really a clue because normal pregnancy can reduce that as well, but it's a low weightage clue. So, not said anything about a gestational sac or normal fetal form appearance, another clue. So clearly, this is a hydatiform mole, and it has its effect as well as it got the the hyperstimulation effect where the ovary is now enlarged and it's got multiple cysts in it. Okay, so the patient is symptomatic. Patient's already got hydatiform mole. We know the patient's got hydatiform mole. MRI abdomen and pelvis for staging is not necessary in this case because we have the diagnosis, number one. The first thing is to get it out. The correct option is actually the one that no one picked. It's the suction and curettage. The serum beta ECG will give us information which we already know. Okay, so we don't need that. That's not correct option. CT yes, but it's done after suction and curettage to see if there has been metastases of the hydatiform mole. Chorionic villus simplex, again, not needed because you can have the thing out and then send it for chromosomal analysis. So again, the correct option in this case is the treatment. Suction and curettage. This is what we do real life as well. If you go back down to your memory of what you do normally in these cases. So ultrasound gives you quite a lot of information, pretty much needs for you. Chromosomal analysis, more centers. That's also done.
We lost
on
you
the
for a
actual
bit there.
sample.
Sorry.
So where did you lose me? How much did you hear and how much did you not hear? I seriously apologize about this. I don't know what's happening. The internet seems to be working fine here.
Hi,
Everyone
Dr.
can hear
Syed.
me now?
Hi. I think when I look at your thing, it has red bars sometimes and it's yellow bars
Okay.
now. But ideally, it needs to get to the point where it's white bars on your. Yeah, now it's good. Now it's good.
Okay.
So
Okay.
that's
We'll
what we
sort again. This is our first time, so obviously we'll make sure that we don't have this issue in the next presentation. But how far did you hear me? Has everyone heard like all the relevant stuff that I wanted to
I think
convey,
it's
or
when
does
you were
anyone has any
mentioning.
questions?
It was when you were mentioning the endometrial suction curettage, and also I don't think you can see that on the screen, so you may need to just pull it down a bit.
There you go. Okay, so no one picked endometrial suction and curettage, which unfortunately is the correct option in here, because as you can see, the patient is symptomatic. The patient has hydatiform mole. It has been diagnosed. Patient is symptomatic. Next step is treatment. All the other stuff, the staging, the chromosomal analysis can be done afterwards. They don't need to be done before we take it out. So in this case, the correct option is the endometrial suction and curettage. I know this is tricky because we are radiologists. We do not think like clinicians. We think like radiologists. For us, it's always the next scan, but that's not always the correct option. So as I said, when you get a simple condition or condition that you've heard about, read about a lot, the question is not going to be straightforward. The question is going to be slightly tricky. So step back and think what the correct option is. So all the information that you need to diagnose is already in the STEM. The next step in management is now treatment. Any questions? I take it none. All right, where are we? I think we getting close to the last bit, so you guys can take a breather soon.
Yeah, I think we can proceed to.
Okay, I'm quite
Yes.
happy that most of you picked up ischemic valve because so this is a breather. This is a simple question. This is something that you come across on call in daily life a lot. Okay, so these are the ones which are life-threatening ones. So you will get the emergency-related questions which are life-threatening. So as per policy, you have to pick those as well. And those we'll probably try not to trick you. Okay, so there's no trick question in this one. Yes, we're talking about portovenous case. We are talking about ischemic valve. We want you to identify this and raise an alert. So a whole lot of questions will be related to this. The next one will be alert the referring team. So about management, what you need to do next, etc., etc. It's not going to be a next scan. It's going to be alert the team. Okay, so questions regarding really important emergency situations will be straightforward. They will be there. They're not going to be too many of them, but they will be there. Just remember, so they'll be either diagnostic or they will be either what the next step in management is. And you, 88% of you, which is pretty good. Most of you have correctly identified it. The clue I gave you is that the air is running all the way to the periphery of the liver, which is how you differentiate it from pneumobilia, which does not go all the way to the periphery. For people who have not had a look at it, just a quick picture for you. So you've got the very clear branching pattern of the portovenous gas as opposed to the pneumobilia. And the other options I've put in here, like iatrogenic, incompetent sphincter of Oddi, choledochal fistula, they cause pneumobilia. But this is not a pneumobilia case. This is an ischemic valve case. Option is ischemic valve, and well done, you all. Most of you picked up the correct option. Any question? Okay, I think we might be at the last question now. Okay, I hope you guys can hear me. After 4 days, consider that 2 days, okay? Ignore the 4. Consider days after 2 days, there is progression or progressive rise in serum creatinine more than 15%.
I think we can move on to answers, Syed.
Okay, so this I've only put because there were so many questions about this. So the renal transplant and renal transplant complications, I think the college is obsessed with the topic, and it's not just this college, it's the Australian college as well. I don't understand why, but there were so many questions about this one. I would strongly recommend that you guys read up on this topic particularly well, okay? And there were all sorts of complications in it. So the way I used to think about it was the pre-renal, the renal, and the post-renal conditions. So the pre-renal are the vascular problems, right? So the arterial or the venous. In case for arterial and venous, they have to give you the waveform because otherwise can't really diagnose it. In case of the kidney, they have to give you some like a DTPA, some nuclear medicine study or rising creatinine, etc., etc. And then the post-renal, which is a like obstructive uropathy, and then the non-renal causes is which is infection or a perirenal abscess or perirenal lymphoma. Renal lymphoma is also a late complication of it. By far amongst these, this is probably the most common one. So you get at least one question about this. By far, the most common one is this acute tubular necrosis, which most of you picked up correctly. And you might have been drawn to this because I said 2 days, because it happens within 4 days, but most of them happen within the first 2 days. So and it characteristically has slow transit, but the vascularity stays fine. So that is the clue. Just go through the rest. Acute transplant rejection occurs within the first few hours, so it doesn't take 2 days. Obstructive uropathy is a late complication. Cyclosporin toxicity is a late complication. And this says chronic transplant rejection again, which is a late complication. Also, they are less common than the acute tubular necrosis, especially if it's a cadaveric renal transplant. So the discussion around this would take a lot longer. So if we started talking about like even lymphoma is a complication, so you can get post-transplant lymphoma in it. So, and there was a question on post-transplant lymphoma. So I would really welcome you all guys. So go and read up on this topic and build your own process of how to get to the correct, because there was many questions on this. I think 4 or 5 at least, all sorts of complications of renal transplant. The only reason I put this in, I hate this topic personally, but I only put it in because again, you get at least good 5 questions right if you're strong in this topic. Any questions? Hello, everyone can hear me, or is my volume lost again?
We can hear you now.
Sort of lost you in the last bit, but we could hear you.
Yeah, but I think we could understand what you were saying there, so that's
The
okay.
most important message here. Yeah, okay. Yes, so the most important information that I wanted to pass on was this is for some reason, this is a very important, very favorite topic of them. So just make sure that you read this very, very well. You will get at least 4 or 5 questions related to this.
Okay, we'll